All right. Good evening, everybody. Welcome to Blueprint Med School Tutors webinar on high-yield EKGs for the USMLE and COMLEX exams. My name is Dr. Joe Hansen, and I've been working with med school tutors as an individual tutor for all medical school exams for the last few years. In that time frame, I've spent over 7,000 hours on camera like this, working with individual students and doing webinars like these to help people prepare for these tests. I'm hoping that experience can help me to get you guys to where you need to go when it comes to answering questions focused on EKGs this evening. I'm joined by Dr. Moses Murdoch. Moses, you want to go ahead and introduce yourself?
Absolutely. Welcome, everyone. So excited to be chatting about EKGs with you. Like Joe, I've spent a lot of time with students one-on-one tutoring them on the various topics that show up on the USMLE and COMLEX exams. I am an internal medicine resident, so EKGs are close to my heart, pun intended. So I'm excited to chat about that with you all today.
Awesome. All right. Well, as you guys are all getting settled in, we'll kind of introduce what we're going to be doing this evening. And to start, I'll just let you know who we are at Blueprint Med School Tutors a little bit. Med School Tutors is a one-to-one online tutoring company. Our main goal is to help students get from technically the pre-med territory and MCATs, but especially through medical school when it comes to coursework exams, STEP exams, shelf exams, and then even beyond moving into residency and residency applications. We're trying to be a one-stop shop when it comes to helping to pair mentors with students who just need some help to become the best possible student and applicant they can be as they're moving through the medical system. We've been in the business for over 15 years, and we've got tons of very experienced individuals who are currently in med school themselves or are residents or fellows or even attendings that have worked with hundreds and hundreds of students like yourself. So if you guys are interested at all in being paired with a mentor of med school tutors, we'll have our contact information up on the screen, and we'll talk a little bit more about that later. For now, though, let's go ahead and jump into our focal topic for tonight. Moses, you want to walk us through what our game plan will be?
Sure thing. So broad strokes, we're going to be starting by giving you all the basics of cardiac conduction, the tools you will need to systematically approach any EKG in simple steps. I know that it can be intimidating to approach EKGs, and we're hoping to give you the tools to analyze them in a way that is efficient so you can get to the right answer on this standardized exams, along with the need to do that in real life. We'll do that in the second half of our webinar by going over commonly tested arrhythmias, walking through our analysis of the EKG strip, pointing out common pitfalls that we'd like you all to avoid so as to maximize your score and your expertise in analyzing EKGs. And we have plenty of additional strips for us to examine, time permitting. I really want to emphasize that along the way, we hope this to be interactive. That's how people learn the best. So please put your thoughts, your questions in the chat. If you notice that one of us is looking off to the side or it looks like this, we're typing, that's because we are. We're probably responding to a question from one of your colleagues in the webinar. And so do forgive us for that.
Excellent. All right. So we'll be asking you questions throughout the conversation this evening, and then we'll be petitioning you guys to send questions to us throughout the conversation. So if there's ever anything that seems like we've run over too quickly or you don't fully understand after we finish talking about it, feel free to send questions in the chat box. Thank you guys for answering what exam you're preparing for here so we can start to sculpt and target the information we'll be talking about this evening regarding EKGs to those tests. So feel free to send us questions and we'll be asking you to participate. And forgive us actually if we're looking over to the side or look like we're not paying too much attention to the screen itself, because we'll be typing answers to your questions directly and asking questions to you in the chat box as well. All right, so with that being said, let's jump straight into how we read an EKG. So the kind of mnemonic we're going to be using this evening, the thing that's going to be most important for us is the combination of rate, rhythm, axis, intervals, and morphology. Now, rate is somewhat self-explanatory. How fast does the heart go? Rhythm, what's the cadence? Or where are the P waves or the QRS complexes relative to one another? Is it a sinus rhythm, which we'll talk about more? Axis is talking about the flow of electricity through the heart. So where exactly is it going to? What direction is it going? And we can use that information to kind of diagnose certain conditions where there might be electrical aberrance going the wrong direction, indicating that we have certain conditions like a bundle branch block or ventricular hypertrophy. Intervals will tell us the spaces between the findings on the EKG, so like the PR interval or the QT interval, and looking at those can help us to identify where there are pauses or interruptions in electrical flow through the heart. Finally, morphology is kind of a catch-all, and that's going to be like the shape of what all the waves look like on the EKG. And every time you see a 12-lead EKG, you should anticipate moving one by one through these criteria: rate, rhythm, axis, intervals, morphology, to the degree that you're capable of doing so with the information provided. Sometimes you don't get a full 12 lead EKG, you might just get one rhythm strip, and that's fine. And to the degree that's necessary. Sometimes you might find the diagnosis presents itself even without having to use all of these criteria as you're moving through. So we're going to walk through these one by one before we look at some examples and sample problems. Moses, do you want to go ahead and take us through how we would evaluate the rate on a 12 lead EKG, like what the rules are that we use to simplify this process for ourselves?
Happy to. So just like Joe was saying, the rate or the speed at which the heart is beating, how many beats there are per minute, is one of the key pieces of information that we glean from an EKG, because rates that are either too slow or too fast can give us clues as to an underlying diagnosis, or it may be the diagnosis itself. Normal heart rates anywhere from 60 to 100 beats per minute, although folks who are really phenomenal athletes can have lower heart rates, and that's not a pathological state. But in general, 60 to 100 is a good rule of thumb. And the approach to how to get the rate on a strip or on a full EKG depends a little bit on whether the rate is regular or irregular. So in other words, if the heartbeats are happening at exactly the same time between each heartbeat, regular, in other words, then you can take the number of big boxes between the QRS, each QRS complex. 300 divided by the number of big boxes will give you your heart rate. Now, if you look at the EKG on this screen, you'll notice that the QRS intervals are not always regular. So then you might ask yourself, which ones do you choose? And that's sort of a trick question, because what I would recommend is, instead of arbitrarily choosing one of the variable QRS to QRS intervals, instead you can look at the total number of QRS complexes in a standard 12-lead EKG and multiply by 6. So let's take this example. I'm looking at that bottommost V5 strip. I'm counting from the left: 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. And so you then 13 multiplied by 6, that comes out to be 78, which in this case is within what we would expect to be a normal rate, a normal heart rate for the individual for whom this EKG was taken. So just to summarize, if it's regular, in other words, there's the same number of big boxes between every QRS interval on your EKG, you just take 300 and divide by that number of big boxes, and you're done. You've got your heart rate. And just to give you a bit of a sense of what's normal, recall that if your normal heart rate is between 60 and 100, that means you would expect the number of big boxes to be between 300 divided by 3 is 100, and 300 divided by 5 is 60. So normal is somewhere between 3 and 5 big boxes in your EKG, or you take the total number of QRS complexes and multiply by 6. Anything to add there, Joe?
No, I'll simply add to it that when we're looking at a 12-lead EKG for the first time, I do want to mention that we will be separating between the 12 actual leads themselves and rhythm strips, which are usually located at the bottom of the image. Now, to clarify, not every EKG will have rhythm strips. And if it does have a rhythm strip, it won't necessarily be all 3 of these leads. You see a re-representation of lead V1, V2, and V5 on this 12-lead EKG. In many cases, you might simply find that the rhythm strip is simply lead 2 alone. The idea here being that we're going to put at least one lead on the bottom of the image to give you a full 10-second picture of what's going on with that particular lead, so that we can better evaluate broader trends that are happening over that time frame. We only get somewhere around 2.5 seconds for each of the leads up top. So sometimes we want to stretch that out. For the purposes of the exam, I'll mention that in many cases, if they give you a 12-lead EKG with multiple rhythm strips at the bottom, not only lead 2, which is the most common one, but also leads V1 and V5, that might behoove you to pay particular attention to those rhythm strips, because they're probably trying to get you to see something that's not totally visible in lead 2. And so they're trying to give you a little bit more room to work with by giving you another lead to investigate. So that might be a clue if you were to see a 12-lead EKG, that they want you to pay attention specifically to things that are noticeable in V1 or V5 that are not noticeable in lead 2. So one thing that Moses has identified here for us was that this particular picture failed the 300, 150, 100 rule, where you take the number of big boxes and you divide the number 300 by that, because we have an irregular rhythm. So if we're looking at rhythm, the most important thing that we want to do is to identify whether it is a sinus rhythm. Now, the thing that you'll be asked on the wards very commonly when it comes to like whether or not something's sinus is like how to define this. And a sinus rhythm by definition is going to be a P wave before every QRS and a QRS after every P wave. And it might sound like I'm being redundant by saying both of those things, but the thing that we don't want to happen is that we don't want a P wave to happen with no following QRS. And we don't want a QRS to spontaneously come out of nowhere without a P wave preceding. There should be a one-to-one relationship between P waves and QRS complexes, because what we're going to find here is that as we're looking at the rhythm here, the idea will be that the SA node should control every ventricular beat. And the SA node depolarization is represented by the P wave, and the ventricular depolarization is represented by the QRS complex. So we should anticipate that we should have one SA node firing, one atrial depolarization for every ventricular depolarization. And if we see that, then we can prove that the SA node is in charge of the ventricles, and therefore we have what would be considered a sinus rhythm. So when your attending asks you, what does it mean to have a sinus rhythm? The answer would be that you have a P wave for every QRS and a QRS for every P wave. And ostensibly then, that would usually be a regular rhythm, unlike the one we saw in the previous slide, which was an irregular rhythm. Moses, anything to add about identifying specifically whether something's a sinus rhythm or not?
That was a wonderful explanation. I saw in the chat that there are some folks here who are taking some of the more advanced exams. So maybe I'll just point out a couple of advanced concepts here before moving on. Just to say that if you want to take your definition of sinus rhythm, in other words, normal rhythm originally from the SA node to the next level, you can see whether the P wave in 2 is upright, which again implies that it's not just that it's coming from somewhere in the atria, not just that there's a one-to-one correspondence between atrial and pacemaker activity and ventricular activity, but that it's actually coming from where it's supposed to be coming. In other words, coming from the sinoatrial node. Another clue there would be biphasic in V1.
Excellent. And I'll add to that then, just to kind of lead us into our next little topic here, is that we can determine the directionality of electrical flow through the heart by evaluating the axis. So Moses, do you want to elaborate a little bit further on what the axis is telling us?
What a flawless transition. Yes. So axis is one of those things that can be pretty confusing. So I'd like to sort of simplify it from a 30,000-foot view and then give you a practical way to actually determine it quickly and accurately. So the whole point of axis is trying to determine whether the flow of electricity through the heart during a cardiac cycle is normal. In a normal heart, you expect it to start in the upper right, let's say, in the SA node, to then that electrical signal to depolarize the atria, to go through the AV node, and eventually to point down into the left. And the reason we expect it to point down into the left is because the EKG is picking up electrical signals generated by the myocytes. And the more myocytes there are, the stronger that signal will be. The left ventricle has the largest number of myocytes, and therefore, when it's depolarizing, it dominates the signal. So we start in the upper right and we move down to the lower left. Thank you, Joe, for putting that arrow in the direction that we would expect the electrical flow to go in terms of direction. Now, when we come to the EKG, practically speaking, if you see an actual patient on whom we're obtaining an EKG, we're putting electrodes, leads on various parts of their arms and legs, and each lead points in a particular direction. And the graphic that you're seeing on the screen is giving you each arrow is pointing to the name of one of the leads that you see on the EKG and the direction in which it goes. If the net electrical flow is pointing in the direction of that lead, the deflection in that lead on the EKG will be positive. If the net direction of flow is moving away from that lead, then the deflection will be negative, okay? So the easiest way to think about obtaining an axis is to look at leads 1 and leads AV And 2 will essentially be a tiebreaker for you. So if you're looking at your EKG and the net deflection is positive in lead 1, that means that the net direction of flow has to be on the right side, the right half of this circle. Furthermore, if the net direction of flow is positive in AVF, in other words, the deflection is positive in AVF, that means that the bottom half of the picture, or the bottom half of that circle, is where the net direction of flow is. So if it's positive in both 1 and positive in AVF, you have normal access. You are done. It's in that green shaded region between 0 degrees and 90 degrees. But of course, it has to be slightly more complicated than that, because you can have a normal axis between 0 and minus 30 degrees. And that's when you look at lead 2. Because if lead 2 is positive, then that means you're in normal axis, assuming 1 and AVF are positive. If lead 2 is negative, then you have the possibility of being there in the left axis deviation. This is a tricky concept to get, but essentially what you're doing is the net direction of electricity moving from the upper right to the lower left, which means that the positive deflections, you should be seeing it in leads that point in that same direction. In other words, leads like 1, 2, and AVF. Why do we care about this? I've spent a long time sort of describing different leads and why there's positive and negative deflections in them. It's because if the distribution of myocytes, if the distribution of mass in the heart is disturbed, in other words, for example, if there's too much mass on the left side, right, left ventricular hypertrophy, or on the right side, then that axis will shift to represent how there is inappropriate mass or electrical activity in those different parts of the heart, and can give you clues to the diagnosis in the vignette or in the patient in real life. Okay, this is one of those topics where hearing 2 different folks talk through it can be really helpful. Joe, how do you describe it to your students or clarify anything that might have been confusing?
I'll merely add on to what you said about looking at electrical activity pointing towards a lead, creating positivity in that lead. To provide an example, if we had an axis that was pointing in the wrong direction, let's say that it was pointing down in this direction, which would happen if we had, like, let's say, right ventricular hypertrophy, like a cor pulmonale type picture, where the right side of the heart would be thicker, stronger, more electrical activity than the left side of the heart. Then we would have a right axis deviation in that case. In that circumstance, electrical activity would be pointing to the left and downwards. And if that were the case, if you looked at leads AVF and lead 1, you would find that AVF is still pretty satisfied. We're pointing kind of downwards. And so AVF would be positively deflected because electricity is pointing towards it. But if we were to look at lead 1, we'd find that electrical activity is pointing firmly away from lead 1 and not towards it, which means that we have a negative deflection here. So as Moses was saying a moment ago, if you look at leads 1 and AVF, you can easily identify which quadrant of the heart that you're in at any one point in time, because we know that pointing down means pointing towards AVF and pointing left means pointing towards lead 1. And so we can easily figure out what it means to point in any other directions. We can figure out if we're pointing down here, we can figure out if we're pointing over here, or over here. So we can determine roughly whether we have left axis deviation, right axis deviation, or the so-called extreme axis deviation merely by looking at 2 leads. And that fundamentally comes from the idea that electrical activity pointing towards a lead causes a positive deflection in that lead. All right, so with that part being said, probably the most complicated part of our initial mnemonic here, I'll go ahead and take us through intervals. So when we are looking at intervals, the idea is that we know that there's a specific length or distance that we're expecting between certain activities in the heart. The ones that we're going to pay most attention to are going to include the PR interval, which is the space from the beginning of the P wave to the peak of the QRS complex. And that is usually going to be less than 1 big box, which accounts for 200 milliseconds. If we were to have a length that were longer than 1 big box for the PR interval, that would imply that we had some kind of delay of the electrical signal going from atrial depolarization down to the ventricles, some kind of AV nodal block, a hint for later on future questions that we'll look at. Meanwhile, we can look at the width of the QRS complex, and the width of the QRS complex should be quite small. We should expect the QRS to happen rapidly. And so that should happen in less than 3 small boxes, which is 120 milliseconds. And so generally speaking, if you have a nice needle-shaped QRS complex like this, I recognize this is a little bit blurry image, but that's probably a narrow or appropriately wide QRS complex. Finally, there is an interval on here that is probably not correct that I haven't mentioned yet. So I'm going to get you guys to start engaging with us a little bit in the chat box here. Can anybody tell me in the chat box what interval is likely abnormal just based on visual inspection here? Can you guys go ahead and type that test in the chat box? I'll give you a second to kind of think about it before I move on here. All right, got a couple of people answering already. Keep them coming. Thank you guys for participating. Really appreciate it. And I'll point out too, by the way, you can choose either to type to everyone or to hosts and panelists here. If you prefer to keep your answer anonymous and only so that Dr. Murdoch and I can see it, you can go ahead and type it to the hosts and panelists through the drop-down menu there. All right, so I see a lot of people saying what amounts to the same thing, which is the QT interval or the ST interval. Now, ST interval is not one that we typically identify. Instead, we start from the beginning of the QRS to measure the QT interval. The QT interval would be from the Q all the way over to the end of the T wave. And the kind of rule of thumb here is that if the QT interval is more than 50% of the distance in the R to R interval, that's probably a little bit too long. Now, there is a way to calculate the corrected QT interval in order to determine whether it's truly long or not. But for me, generally speaking on the exam, if it's longer than 500 milliseconds, that's too long. And 500 milliseconds would be 2.5 big boxes. So excellent answers, everybody. Virtually everybody said QT or ST interval. QT interval is the one that you're going to see on the exam. That's the one that you should be paying attention to in terms of the terminology that we'll be using here. One more thing to ask you guys, since we're getting warmed up here. This is a long QT. So what very specific arrhythmia would this patient be susceptible to if we have a long QT? All right, already getting some answers here. Keep them coming. Let me know if you guys know the answer to this one. Very good. All right. So awesome job, everybody. Thanks for participating. And the answer is torsade or torsade de poids, which is the kind of signal that typically tends to look like this. The twisting of points picture. A polymorphic ventricular tachycardia is the one that we're most worried about when we have a long QT, whether it's an acquired or a congenital long QT. Anything to add to our intervals assessment, Moses?
No, that was excellent.
Cool, thank you. All right, well then in that case, take us home with our last major thing to look for in a mnemonic. What's the morphology? What are we looking for here?
So morphology is this broad bucket that encompasses abnormalities in the shapes of the various deflections on the EKG. So we have the P wave, we have the QRS complex, we have the T wave. All of these, if you look at enough EKGs, they will have a very normal and characteristic shape dependent on the person, their underlying diseases, and which lead you're looking at. But there are some very classic abnormalities in the shapes and the displacement of these different components of the EKG and of the cardiac cycle that are pathognomonic for particular diseases, and you should be able to recognize. The slides, this one and the couple next ones, will not be an exhaustive sort of encyclopedia of all the different possible morphologic changes, but they do highlight some of the big ones. So again, we'd like to get you all really sort of involved here. This is a 12-lead EKG. In the chat, go ahead and put what the major abnormality here is. What are we seeing in this EKG? And I'm already seeing tons of correct answers. Again, I mentioned that morphologies can involve any of the different components of the cardiac cycle as reflected in the EKG. This one in particular is an abnormality of the ST segment, right? So the ST segment, as many of you are pointing out in the chat, is inappropriately elevated. And Joe, thank you for highlighting. It's in particular leads. Remember that particular leads can give you a clue as to where in the heart pathology is present. So next level question for you all. Given this pattern of ST elevations in 2, in 3, and in AVF, what diagnosis are we thinking of and what part of the heart is involved? And I can't get anything by you because folks are pointing out that it is an inferior MI. Beautiful. And which artery might be most likely involved? Wonderful. Remember that there's right dominant and left dominant circulation. So RCA is a great answer, but that won't be for 100% of patients, but it's a good, most common answer for the exam. So this is an example of an abnormality in the ST segment. If we move to the next slide, it'll give you the answer. Inferior MI, just as you all said. And then the next couple of slides will really just be examples of morphologic issues in other parts of the cardiac cycle. So here we're focusing in on the P waves. Here are two examples of abnormalities. Go ahead, again, being active and coats this stuff in your memory. That top P wave and that top image, what classic name do we give to this finding and what is it associated with? I gave you the answer in the image, but here we're looking for what that particular shape, the morphology of this P wave, what does that tell you? It's a little bit tougher. So we're looking for something to do with the P wave, something to do with the P wave. It's called P mitrale. And as a clue, the bottom, P pulmonale. Love it. Some folks are putting in the chat atrial enlargement, and the actual shape of it, the actual morphology will give you a clue as to which chamber is involved. So P mitrale, left atrial enlargement, P pulmonale, the so-called Himalayan P wave, right atrial enlargement. Wonderful.
Beautiful. All right.
There might be one more to think about the T waves. And here I'll be very quick. Just another example of a morphology that's abnormal. If I told you that these T waves are peaked, for instance, and there's an electrolyte abnormality, what electrolyte would you be suspicious would be causing this? And I love the folks who just put one letter, K, absolutely right. So hyperkalemia can give you peaked T waves. Of course, in more advanced forms, you can end up with a very dangerous arrhythmia, sort of the sine wave. That's just a taste of the different morphologic features that can happen in the various parts of the cardiac cycle as represented on the EKG. Anything to add there, Joe?
No, excellently done. We'll go ahead and move on to talk about actual arrhythmias now and how we would apply the concepts that we've been talking through. So I'll kind of talk us through the idea of a tachyarrhythmia. Now, tachyarrhythmia simply means fast arrhythmia, essentially here. And one thing I want to emphasize right off the bat is that when you see somebody who has what appears to be a tachyarrhythmia, meaning really fast heart rate, the one thing that you want to identify right off the bat is the interval for the QRS and identify whether you have the appropriately sized, less than 120 millisecond, less than 3 small box, narrow complex, or whether you have a wide complex, meaning greater than 3 small boxes. So just to kind of draw out what that would look like, obviously a narrow QRS would look nice and sharp and narrow. A wide complex could have a very particular look, but usually just fatter looking essentially. And so when we're looking at a tachyarrhythmia, we merely mean that it's going fast, that we have a fast ventricular rate, fast QRS complexes, lots of them. We could have a regular or irregular rhythm depending on the type of problem that's occurring here. But let me specify really quickly, the reason that we're looking at the QRS interval is because you can generally identify whether you're looking at a supraventricular arrhythmia, meaning something happening above the ventricles in the atria or somewhere thereabouts in the AV node, versus a ventricular arrhythmia where the ventricles themselves are having a problem. And the simplest way I can describe this is to say, if you have a normal, narrow QRS complex, you have your left ventricle and you have your right ventricle, and they're firing at the same time, meaning the electrical activity you're seeing is superimposed. They're happening simultaneously. If you were to have an arrhythmia where you started seeing the left ventricle depolarize before the right ventricle, or vice versa, then you would have a wider QRS because it takes longer to complete the cycle of ventricular depolarization. So if you have a signal that's going around the ventricles, a ventricular arrhythmia, that will usually be a wide QRS. If we're looking at a narrow complex QRS, however, that generally means that both ventricles are depolarizing at the same time, which means electrical activity started from the center and radiated outwards, meaning the AV node fired appropriately, or at least something thereabout fired appropriately, which means that we have pretty good overlap between the two ventricles firing. This is a really easy way then on virtually any exam to immediately identify any arrhythmia as being supraventricular or ventricular. From there, we would then want to identify whether it's a regular rhythm, which generally is going to be one with a reentrant loop, or whether it's an irregular rhythm where we have stuttering appearance, where sometimes electrical signals are not going the way they're supposed to. And so we have gaps and pauses and kind of a staccato appearance to the QRS complexes. That applies both to a wide and to a narrow QRS complex. Really good examples, for instance, of somebody who's got a narrow QRS supraventricular arrhythmia, let's say a flutter. The atria are going crazy, sending signals down to the ventricles. Meanwhile, a wide QRS arrhythmia might be something like ventricular tachycardia, where the ventricles are now firing on their own with no regard to any signals they receive from above or from the AV node. So, general introduction there. We'll talk through some more specific examples and give you some examples. Anything to add to this before we take a look at an example, Moses?
The only thing I would say is that description of what actually leads to a wide complex versus what leads to a narrow complex is really great because it extends even beyond tachycardias. In other words, some folks in the chat just earlier when thinking about other of the basics of the EKG had brought up the possibility of, let's say, a bundle branch block. So if there is damage to the electrical system such that you do not get simultaneous excitation of the right and the left ventricle, the QRS will widen even at a normal heart rate, and you will get what we call either a right or a left or a partial bundled branch block. But this is a key distinction for tachyarrhythmias because it gives us a clue as to where the problem is.
Beautiful. And I'll just pivot off of that to say also that in many cases you might find in patients you see in the hospital, a little bit distracted from the actual exams themselves, that you'll have a wide complex that comes out of nowhere. Just one really weird looking beat on somebody who's on telemetry where you're watching a continuous EKG, which we usually call a ventricular premature contraction or premature ventricular contraction, a PVC. And what's happening there is that the ventricle is just like spontaneously fired one time. Not usually dangerous, especially if they're isolated, but can look really weird on the EKG. And that just happens from time to time, generally more frequently with pathology, but even in healthy individuals, we'll see random PVCs, especially in people who are stressed out, exercising, who already have tachycardia. The ventricles might just get a little antsy and fire too early, meaning that you see a weird ventricular beat with a wide QRS complex. All right, so let's look at some examples of tachyarrhythmias. Moses, you want to go ahead and lead us through these examples?
Perfect. So this is a great example to start out with because it compares and contrasts two really important rhythms that you really don't want to miss because they have big consequences for patients and they can sometimes be confusing to tell apart. For the sake of time, we'll assume that we know that this is a tachycardia. We talked about rate earlier. You could do the big boxes counting. You could look at the number and multiply by 6. Let's just say we're in tachycardia land. As Joe taught us, the very first thing we look at is whether it is a wide QRS or a narrow QRS. So in the chat, you've got a 50-50 shot, flip a coin. What do you think? Wide or narrow? Recall that we're using 120, 3 small boxes as our cutoff, and beautiful, everyone in the chat, wide. So now let's start with the one up top. And Jill already planted this seed a little earlier in the webinar by drawing it out. It's wide, and you look at the amplitude of the QRSs, and we notice that it is variable. And we have the clue that you'll probably get from the vignette that there's an overdose on tricyclic antidepressants. So with that piece of information, sort of variable amplitude, and this association with a tricyclic TCA, what diagnosis can we come to? Go ahead and put it in the chat. Beautiful. You all are exactly right. We're talking about torsades. And now I'll just compare and contrast it to the bottom case, in which case the amplitude of the QRS is more or less the same across each beat, right? It's still wide. And we know that there's a structural abnormality of the heart because of a prior MI. So what diagnosis does this suggest? Go ahead and pop it into the chat. The broadest term for this would be a monomorphic, in other words, mono, same, morphic, morphology, ventricular tachycardia. So this is VTach, very dangerous. If folks don't have a pulse, you're going down the ACLS pathway because this can be extremely dangerous for the patient. So ventricular tachycardia, that's exactly right.
All right.
Anything to add there, Joe?
No, but I'll pivot to say, well, can you explain to our audience the difference between ventricular tachycardia and VFib, because this is sometimes not super easy to notice when we're first looking at these things.
Absolutely. So ventricular fibrillation, and I've said this a couple of times before, to me, I think about it as the atrial fibrillation of the ventricles. So if you had Superman X-ray vision and you could actually look at the heart, what you would see is that one, the atria are not in charge of what's going on here anymore. There's no regular rhythm that's coming from above the AV node. And two, the ventricles are completely disorganized. There's no pattern here, essentially, none at all. You can think of the ventricles as quivering, and that quivering, disorganized foci of electrical activities in various parts of the myocardium is represented on the EKG strip as just a jumble, a mess of a baseline that you can't make heads or tails out of. This is in contrast to ventricular tachycardia, still dangerous, don't get me wrong, but there is an order, there's an underlying sort of pattern to what's going on. Either there's electrical activity going around a scar, right? A reentrant sort of circuit somewhere in the myocardium, or like in the example of something polymorphic, right? You can link that back to a drug or an electrolyte abnormality. There's a pattern that you can detect. With ventricular fibrillation, there's quivering there. There's no pattern whatsoever. You could even use the bag of worms analogy that is often used for atrial fibrillation. But in this case, it's not just the baseline between QRS complexes, it's the entire EKG.
Beautiful. All right. So with that being said, we're going to pivot over to a new example here. And this one, I'm going to note, we don't have a rhythm strip on this one, which is a little interesting, but we can still generally assess what our rate looks like. So if we're following through with our normal rules, rate, rhythm, starting with our rate, the thing that we can do here is count the number of big boxes that we have between each QRS complex. So these would be two different QRS complexes, and the distance between them, as I can see in multiple leads, is just around 4 boxes, give or take. And if that's the case, the heart rate actually is closer to around 75, which means I'm kind of cheating a little bit because we're technically not tachycardic here. Nevertheless, we could be with this particular pathology. The thing that I'm really noticing here is that, number one, the morphology is a little bit weird insofar as I can see there's a lot going on in between these QRS complexes. And also, if I'm following our mnemonic and I look at the rhythm here, I'm not really so certain that I could say this is a sinus rhythm, because I'm not really sure that I see the normal 1 P wave for every QRS rule that we talked about before. We seem to have abrogated that. So I'm going to ask you guys in the chat, what's our likely diagnosis with this particular picture, this kind of sharp picture that we see of multiple different little peaks that are happening between each QRS complex here? Oh, you guys were ready to go on that one. Okay, so keep them coming. I'll give you guys another second to type it in for those who haven't already. So very good. This is atrial flutter that we're seeing here. It's a rhythm that is basically chasing its own tail in the atria, circling around super duper fast. It appears here that we're going somewhere around 280 to 300 times per minute. And I'll specifically point out here that we would call this an A flutter with a 4-to-1 block or 4-to-1 ratio. What we mean by that is that I can clearly see that there are 3 P waves in between every QRS complex. And we're saying we have a 4-to-1 block here. So I want to be clear, these P waves aren't stopping. There is another P wave right here where that QRS complex is occurring, but the QRS is bigger, so it's not easy to see. They're superimposed on each other. So technically, for every 1 QRS, there are 4 individual P waves that we're seeing. Now, because we have a 4-to-1 ratio right now, that means that we technically have a ventricular rate that looks pretty normal, but it wouldn't take much to send this patient into maybe a 3-to-1 block, in which case they start looking quite tachycardic in that case. So this could become a tachyarrhythmia. A flutter here in this particular example has a normal rate, but it definitely could go faster. I'll go ahead and pivot over you, Moses, and hand you over the next one since everybody answered that one so quickly. You want to take us through our next example here?
Perfect. I'll just make one small comment about the atrial flutter,
Sure.
just to say that to help remember this 3-to-1, but there's one hiding behind the QRS. For me, it was helpful to keep in mind what was actually happening in the heart. You have this ring around the tricuspid annulus, and I just imagine an electrical sort of circuit that's going round and round and round, and it's sending off electrical information down to the AV node. And the AV node's the guard. It's saying, I'm not going to let just any old signal pass. There's a latency, right? And so that tricuspid sort of annular circuit is going on constantly. And every so often, especially if it's regular, the AV node will let one of them pass and you see a QRS. That's why we say that there is a sawtooth hiding behind the QRS, because that circuit keeps on going. And this is of clinical importance because medications like beta blockers, not super great at treating atrial flutter. You often need something called a cable tricuspid isthmus ablation that electrophysiologists will do to help break that circuit, right? This is now advanced stuff, and you don't have to remember this for the exam, but it's helpful for me to remember that why it is that these sawtooths go on uninterrupted despite the appearance of QRSs on the EKG strip. All right, I won't bore you all with electrophysiology any further. And I will admit that
thank you for the expert analysis there. Appreciate it.
No problem. I have to apologize to everyone in the webinar because we told you that we would be talking about tachyarrhythmias. And for the astute among you, you might note that maybe this one isn't technically a tachyarrhythmia if you count it out. But regardless, these imposing red arrows, which I admit will probably not show up on your exam, are highlighting a key finding that'll help you make the diagnosis in a patient who could snap into a tachyarrhythmia and might present as a vignette. So in this case, what the arrows are pointing to are a change in the slope between the initial part of the QRS, that upslope, and then the rest of the QRS. So in the chat, what disease is associated with this particular pattern of change in the slope of the QRS? Folks are just all over this. Absolutely. So this is pathognomonic for Wolff, Parkinson, White, the delta wave. And a bit of a more advanced question for you all. If someone is having a very fast rhythm, I'd like to slow them down. And I propose, let's give them some beta blockers. We use this pretty commonly for atrial fibrillation, atrial flutter. Would that be a good idea in Wolff, Parkinson, White? What do you all think? Good idea, bad idea? I'm seeing a lot of
the yes/no question, actually, than for the harder question.
I think a lot of the folks in the chat are exactly right. This is a bad idea, right? We have a reentrant circuit here. We don't want to use beta blockers. Instead, you can use something like procainamide. Anything to add, Joe?
I just want to reemphasize that when you see Wolff, Parkinson, White on the exam, and the exam extends through basically all the step exams and COMLEX exams, the answer in terms of what you should utilize is procainamide, typically more of a step 2, level 2 question specifically, but procainamide is the drug of choice that the exam typically will utilize for Wolff, Parkinson, White. As Moses mentioned, using anything that would slow down the AV node, meaning class 2 or class 4 antiarrhythmics, and especially adenosine, would be things that would help to precipitate a new arrhythmia in the individual. And this gets a little bit complicated, but I'll simply say that typically Wolff, Parkinson, White is going to be a supraventricular tachycardia, a reentrant loop that goes through the AV node and causes the ventricles to fire very quickly. But by using any kind of nodal blocking agent, you could precipitate a ventricular arrhythmia. And so there are rare circumstances where they might ask on the exam what's going on in this person who was given a beta blocker, given a calcium channel blocker, or specifically given adenosine, and now they have a ventricular arrhythmia, which is a little weird with wide QRS complex because that's not what you would expect to see for the typical 15-year-old kid coming in with a narrow complex tachycardia, which is the more bread and butter picture for Wolff, Parkinson, White. Great, excellent job walking us through that, Moses. I'll go ahead and pivot us over very quickly to bradyarrhythmias and say that when we're talking about bradyarrhythmias, we're talking about generally slowing down the signal propagation from the atria down to the ventricles. As I mentioned before, when I was talking about supraventricular versus ventricular arrhythmias, if we were to slow down the AV node, then we would make it so that we can't propagate signals from the atria down to the ventricles and thereby lose the sinus nature of our rhythm. We would no longer be sinus if we could not get the SA node to control the ventricles. That being said, I don't want to steal your thunder here, Moses, so I'll let you walk us through the rest of the introduction to bradyarrhythmias here.
No, that's perfect. So Brady too slow, there's an arrhythmia. The big picture of what we're trying to do here with bradyarrhythmias is figure out where is it that the problem is located, right? And that problem is typically in the conduction system, somewhere between the SA node and the AV node, and we really focus a lot on the AV node. So we define the degree of the block, as you can see in this table, 1 to 3rd degree, and there's 2 versions of 2nd degree block, by where that block is occurring and what pattern we see on the EKG. So just to walk you through this, 1st degree AV block, the way I think about it is it's just taking more time for that signal to get from the SA node, right, and through the AV node. And so that manifests as a PR interval that is 1, constant. In other words, it's not changing, which will be different than some of the other bradyarrhythmias that we'll see. But it's also just consistently above 200 milliseconds, 0.2 seconds. And this is often not that big of a deal. You don't really treat it. It's more of a diagnostic thing. When we start getting into 2nd degree AV blocks, here is where we pay very close attention to the relationship between the P waves, the QRS complexes, the length between them throughout the rhythm strip, and the pattern of lost or dropped QRS complexes. 2nd degree Mobitz type 1, pretty easy to identify once you're clued into the pattern. The PR interval widens with successive cardiac cycles. And then you have a P wave that doesn't have an associated QRS. That's the dropped QRS, okay? And the way that you classically look at this is you look at the QRS right after a dropped beat and the one right before a dropped beat, and you compare the PR interval, right? The one right before the drop beat, really, really long. The right afterwards, pretty short. Here's a subtle point, and one that Joe has made really beautifully in past webinars, is that when you drop a beat, if you just take a step back, it looks sort of irregular, right? Because you're seeing, okay, there's a QRS, there's a QRS, and then suddenly there's not one, and it breaks the pattern. So it just grossly looks irregular. With 2nd degree Mobitz type 2, bradyarrhythmia, AV block, you have dropping of beats, but you don't see that lengthening. The PR interval stays exactly the same. You just drop a QRS intermittently. Both type 1 and type 2 Mobitz, 2nd degree AV block, can be asymptomatic, but it's really important to figure out whether you're in the Mobitz type 2 category, because that has more of a potential hemodynamic impact, progression to 3rd degree AV block, and those folks generally need a pacemaker. So that might come up as part of a management question on some of the later examinations that you might be taking. Now, 3rd degree AV block is when the atria and the ventricles are going their separate ways. They have a quarrel and they want nothing to do with each other. They're not talking to each other. There is a problem in their connection through the AV node and the Purkinje system. There's 0 communication. So what you will see is that the P waves will be marching along at their faster rate regularly, and you have ventricular rates that's going at its independent ventricular slower rate. And because you don't have the AV node and the systems below it to coordinately sort of contract and coordinate the ventricles, you will tend to see a wider QRS. But key, both the P to P interval and the QRS to QRS interval are consistent, right? They're regular in that rhythm strip. Now, this can be really confusing, and we'll see an example of this because sometimes by pure chance, by pure coincidence, you will see a P wave and you'll see a QRS and you'll be tempted to say, that P wave caused that QRS. But that's just because of the way it lined up. That P wave happened to coincide to just prior to that QRS. And you need to be very careful not to inappropriately think that the two are structurally and anatomically linked in an electrical way. And these folks definitely need a pacemaker because the rates can be very slow, can have hemodynamic consequences. And so you really want to be able to pick this up. Joe, you're the bradyarrhythmia master. What did I miss?
I didn't miss a thing. I do want to simplify this, as the table is already done for us, to say on the exam, if there is an intervention that's asked about, which is more of a step 2 level question, we're going to anticipate that we want to use a pacemaker and implantable cardiac defibrillator for 2nd degree 2 and 3rd degree. Meanwhile, we don't need to do anything at all for people who have 1st degree and 2nd degree type 1. So the first 2 diagnoses do nothing. The second 2 diagnoses do something. And the reason, as Moses had mentioned, is that 3rd degree heart block can very commonly create actual symptoms, including syncope, but also can degenerate into a ventricular arrhythmia very easily, which can lead to sudden cardiac death. And because 2nd degree type 2 can over time become 3rd degree heart block, you don't want to leave that person without therapy either, because they can spontaneously convert to 3rd degree and then spontaneously convert to ventricular arrhythmia, which could be fatal without even seeing a physician in the interim. So we're going to treat for 2nd degree type 2. We're going to treat for 3rd degree. We're not going to treat for the first 2 diagnoses here. Let's go ahead and take a look at an example, because I think that that will help to clarify what we're looking for here. Before we do, I'll simply reiterate, as we're looking at these, generally speaking, 1st degree is going to be a regular rhythm because you don't actually drop any beats. So totally regular, even sinus rhythm in that case. In 2nd degree type 1 and 2nd degree type 2, we're going to drop a random beat. Now, it might be predictable in the case of 2nd degree type 1. You can see it coming, but it still drops a beat. Whereas in 2nd degree type 2, you're going to drop a beat randomly. Either way, you drop a beat and you now have what would be considered an irregular rhythm. The QRS complexes are varying distances apart. For 3rd degree heart block, as Moses had mentioned, you ironically come back to having a regular rhythm again. Now, it's not sinus at all, because the SA node is not in control of the QRS complexes. They are totally separated from one another. But the ventricles are now their own master and are just firing on their own, not being told what to do, which means they're going to fire regularly, but their automaticity is a lot slower than what you might find from nodal tissue. So as a result, you're going to find that you have usually bradycardia, but regular bradycardia, and not sinus because the SA node is not in charge, but regular bradycardia. So 1st degree and 3rd degree, regular. 2nd degrees, irregular, is one way we can break these down. With that in mind, now that I've hopefully properly primed you guys, if we take a look at our example, Moses, you want to talk us through what we're seeing on this one?
Sure thing. So here we're dealing with a bradyarrhythmia. We could do that by marching it out, by looking at the QRS or counting the number of beats. This one might be a little borderline, but in any case, the key thing that we're trying to assess is the relationship between the P waves and the QRS. So the first thing we do is we look at all of the QRS complexes, and I'm seeing a P wave before each of them. And what I'm noticing is that the PR interval looks long to me. I think that we actually talked earlier about PVCs. There might be a PAC somewhere here, but in any case, that PR interval is a little bit long. The number I'm looking at is greater than 200 milliseconds. So again, getting everyone involved in the chat. What type of AV block do we find if there are no dropped beats, it's regular, there's a P before every QRS and there's an association there, but the PR interval is longer than what we consider normal, 200 milliseconds. Chat, what do you think this is? What type of AV block? And so as folks are answering the chat, I'll just respond to some of them as I see them come through. Lots of folks saying 1st degree. I like that, right? So it's just a lengthening of the PR interval. Wonderful. Now with Mobitz type 1 or 2, I would expect to see dropped beats. And here I'm not seeing any dropped beats. I'm not seeing a P wave that doesn't have a QRS right after it. So for me, that makes a Mobitz type 1 or Mobitz type 2 less likely. So this is sinus. In other words, the SA node is in charge of the QRS complexes. It's the conductor to this electrical symphony. And the PR interval is long. There are no drop beats. That puts us in 1st degree AV block territory.
Excellent. All right. I agree with Moses here. We chose a unique example to use here because there is something atypical happening with exactly one of these beats here, which I'll take his word for it that a premature atrial contraction could explain that, but that's the weird one. Apart from that, though, we find there's a P wave for every QRS complex on here and a QRS for every P wave, which means it's sinus. Now, one thing we didn't talk about explicitly before is that a sinus rhythm doesn't necessarily mean anything about the rate. You can definitely have sinus tachycardia, or you can have sinus bradycardia, meaning the SA node can be in charge, and yet you still have a slow or a fast rate, which is intuitive because ideally most individuals who are exercising would be tachycardic, but it would be sinus tachycardia because the SA node is in control. In this case, sinus bradycardia, it's a little bit confusing as to why that might be happening here, but the first degree AV nodal block is not the cause of an irregular rhythm. To answer a question that just came in, thank you for asking. If we're looking at lead V1, that's our rhythm strip in this case. I want to clarify, it's the only rhythm strip we got. We could have used lead 2 as a rhythm strip, but for whatever reason, whoever curated this EKG chose to print out, or I guess take a screenshot of a version that had lead V1 as the rhythm strip. You can technically use anything as a rhythm strip. Very commonly, we're probably going to use lead 2, but V1 and V5 are common as well. One of the reasons we really like lead 2 is because lead 2 points down into the left, and that's the same direction as the axis of our heart. So we usually get a very nice, clear QRS complex and usually a very nice, clear P wave as well, because the direction of electrical activity is propagating down into the left from both the SA node and the AV node. So lead 2 is usually an easy answer for our rhythm strip. The V leads are on the anterior chest, and you can get a pretty clear picture in them as well. And sometimes they can show us things that aren't evident in lead 2. That being said, we could have used whatever we wanted. In this particular case, the question just happens to use V1, and that's not something you'll have control over on the exam when they show you an image and you just have to kind of respond to what they've got. Moses, anything to add about our first degree heart block here before we take a look at another example?
No, take it away.
All right, so our next example here, we're going to look at our rhythm strip, and once again, we've chosen V1 as our rhythm strip. And the first thing we do is our rate. And this should be a little intuitive in this case. If we look at the distance between the QRS complexes, I'm counting somewhere on the order of, 8 or 9 blocks between them. And then maybe even easier in this case would just simply be to count these out and say we have 1, 2, 3, 4, 5, I suppose 6 if we're being generous in terms of the number of QRS complexes that we have there. Over 10 seconds, we have 6 beats. That means over 60 seconds, we're going to have 36 beats. Bradycardic. So this is definitely bradycardia, very slow heart rate that we're seeing here. And now I'm just going to kind of like help us out a little bit because this is a little bit of a blurry image. And unfortunately, the exam sometimes has some blurry ones on there too. So this is real-time practice. Looks like I see a P wave there, 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 there. So my first question to you guys is this sinus? So yes or no question for you guys first on this one. Okay, good. All right. Thank you for answering. And you guys weren't anticipating me to ask you that question. These guys are typing it out this time. So caught you off guard. So I'm doing a good job mixing things up. So this is not sinus. And we can tell because we see multiple P waves before a single QRS. There's not a 1-to-1 ratio between these. However, my other question for you is this. Is this a regular rhythm that we're looking at here? Very good. This is regular. The R to R interval is consistent throughout. With that being said, now it's time to make our diagnosis. It's a bradyarrhythmia. It's not sinus, but it is regular. So based on what I said before, what is the diagnosis in this case? We have 2 competing answers in the everyone chat here. I'd like a couple more people to try it out. Some of you guys are responding directly to me and Moses to hide your answers, which is totally fine too. But now we've got a 50-50 in the everybody chat. Okay, so we got a collection of answers here now. So I'll point out that if we were looking at somebody who developed a Mobitz arrhythmia, meaning Mobitz 1 or Mobitz 2, meaning second degree, we would have random and chaotic dropped beats. Sometimes you drop a beat, sometimes you wouldn't, but that means that it cannot be regular in that case, because you will sporadically drop beats, meaning that the R to R interval eventually has to change in either second degree type 1 or second degree type 2. First degree has no dropped beats. I can clearly see there are lots of dropped beats here. In fact, there is no relationship between the P waves and the QRS complexes. So the correct answer, as many of you have written out, is third degree avianodal block here. And as Moses had said before, it's kind of hard to tell, like, I don't know, maybe this P wave is, I should make that more clear, maybe this P wave is causing that QRS complex. It's kind of hard. Like this one looks like it might be causing that QRS complex. It looks like a P wave leading into a QRS complex at the very end. But the thing is that because there's no dropped beats, I mean, the QRS complexes are regular in this case. They're going consistently. It means that these P waves cannot be in charge of those QRS complexes. They must be working autonomously. It must mean there's literally no connection between these. So sometimes it's really hard to pick between second degree and third degree. And the simple solution is it regular? If it's regular, the QRS complex is happening consistently, normal, regular, equal R to R intervals, it's got to be third degree in that case. And that's how you're going to break the tie between those answer choices.
The only thing I'll jump in here to say, Joe, is that when we were discussing the table, we said that the atria are going at their own regular rate and the ventricles are going at their own regular rate. Remember, though, that if in a wrestling match between an atrial depolarization and a ventricular one, the ventricular one will always win. There's just so much more mass. So when you were really nicely illustrating the marching out of the P waves, it might have looked like there was a loved up pattern to it, where it was too close together and then too close together and then too close together. But the point is, as you're pointing out now with the hearts, is that the P waves were actually still marching out at a regular rhythm, except that we couldn't see them because the QRS complex was sort of standing in front of it. It was obscuring our view of the underlying P wave. And actually, for advanced EKG enthusiasts, sometimes you'll know that there are subtle differences between the QRS complexes that have a P wave hiding behind them and those that don't, because there's an extra little squiggle. Will this matter for you on your exam? Probably not. But if you do see it, that's could be another clue and the explanation for the underlying physiology of what's showing up on the EKG.
Beautiful. I believe you're describing a fusion beat in that case, which does show up on a couple of URL questions for step 2 specifically, though they don't actually ask you to define it. They just mention it in the explanation. So nothing to worry about for the actual exam itself. All right, awesome. Thank you for the bonus there, Moses. I'm going to go ahead and pivot us to our rapid fire section now. So stick around with us as we kind of like wrap things up this evening by just jumping into some rhythm strips. As you will likely see on your exam, sometimes they'll just give you a rhythm strip, not even the full 12 lead EKG. They won't even tell you what lead you're looking at in some cases. And so we just got to be able to recognize these as a visual diagnosis. So I'll jump us into our first one here. Can anybody tell me what you think is happening here? So this is just hardcore, straight up, give me a diagnosis here. What do you guys think we're seeing in this case? As you are thinking, I will start giving you little hints to this, and I'll point out that if I'm looking at the R to R interval, it appears relatively regular. If I'm looking at whether or not there's a P wave here, I'm going to find that there's a P wave here, there's a P wave here, there's a P wave here. So if I'm looking at the ratio of P wave to QRS, it looks like I've got a 1-to-1 ratio. So I guess I'll ask this then. Okay, good. We're getting some answers coming in. Ask yourself this, is it sinus? And then ask yourself this, what's the rate? And if we put those two together, we can start getting closer to what our answer might be. If we do our rate and rhythm, as we're usually supposed to, we'll find that this is going to be tachycardic. There's 2 big boxes between every beat, which means the heart rate's 150, 300 divided by 2. And we see that we have a P wave before every QRS, a QRS after every P wave. Many of you have already answered this correctly. Thank you for playing along. This is sinus tachycardia that we're seeing here, which is a tachyarrhythmia. It's simply controlled by the SA node. So this might be a person who is panicking or exercising or something along those lines. It might not represent an actual pathology, but it's still something we're going to have to recognize very commonly in the ED when you're looking at an EKG. All right. Anything to add to that, Moses?
No, that was great. The only thing I'll say is, and this can be tricky, is that when the heart rate goes really fast, the RR interval gets shorter, which means that the T wave can start running into the P wave, and that can make it look a little odd. So don't be faked out by that, but certainly keep the morphology of the P wave and the morphology of the T wave in mind, as they can point to additional pathology.
I'm going to add to that a little bit too and mention something that we didn't say before. When we were talking about the QT interval, we mentioned that one way to look at the QT interval is to say, is the QT interval taking up 50% or more of the space until the next QRS complex? Because if the T wave ends more than 50% of the way to the next one, that's probably a long QT. But if we look at that, then like there's not very much space between the QRS complexes in this case because of the tachycardia. And this is the reason that you might eventually need to consider the existence of the corrected QT interval. The idea being that a faster heart rate generally allows for less of a QT interval before we start calling it a long QT. So the heart rate actually does have something to do, that is to say the RR interval has something to do with whether or not it's long QT, which is why I said before, generally 2.5 big boxes would be considered a long QT to me and somebody who's not tachycardic, but clearly 2.5 big boxes would place the T wave after the next QRS complex in this case. So it doesn't work anymore. You can't say 500 milliseconds is your absolute maximum here because of the tachycardia. Suffice it to say, tachycardia can help to reveal the development of torsade in somebody who has a long QT. And so for questions that you see in pediatrics, for instance, step 2, you see a young child running around and then just falls over while they're running around with a syncopal episode, and then they describe that it's not a seizure, they don't have any post-ictal confusion, you could consider maybe they had a long QT and the running around, the exercising they did led to the development of torsade because you precipitated torsade by causing tachycardia. And suffice it to add in one more time, if somebody dies spontaneously by drowning on the exam, they'll commonly say, 5-year-old kid comes in, they passed out on the soccer field. By the way, they have an older sibling who tragically died in a drowning event. It's very likely that you have a congenital long QT. That sibling who died by drowning is a buzz term essentially on the exam, indicating that they experienced an arrhythmia while swimming, which is not survivable if it's not witnessed, obviously. So the idea there being that the QT interval actually depends upon the RR interval, and that's why there's no one solid number that we use for it. And we can identify questions on the exam that are talking about a congenital long QT by finding that people pass out or develop a syncopal episode arrhythmia during exercise or during exertion. All right, said enough on that, Moses. I'll go ahead and pivot it back over to you as we take a look at our next example here.
Perfect. So here I'd like to focus everyone's attention. We'll try to do these relatively quickly to develop that instinct for identifying different rhythms. Here we're looking at the rhythm and we're looking at the morphology of the P waves, or clue, the absence of P waves. So here the rhythm is irregular, right? The RR interval is not consistent across the rhythm strip. And then if we look for P waves, we definitely see squiggles. That's the technical term, squiggles. But I'm not convinced that I'm actually seeing one morphology that I can reliably call a P wave. So if I have an irregular rhythm, no P waves, and an irregular baseline, irregular rhythm, what do we call that? What diagnosis? Go ahead and put it in the chat. We already have one answer. Atrial fibrillation is absolutely correct. When the rates in atrial fibrillation are very high, that can cause hemodynamic instability, and we control that with beta blockers. If folks are anticoagulated, you can cardiovert them. You can use antiarrhythmics. The bottom strip is a common mimic, so it's also a narrow, complex, irregular rhythm. But here we can, if we squint, we can sort of convince ourselves that there are P waves, but we notice that the morphology of the P waves differs. And the clue here, you have at least 3 different morphologies to the P waves. So what diagnosis is suggested by an irregular rhythm with at least 3 different P wave morphologies? Go ahead and drop that in the chat. Beautiful, multifocal atrial tachycardia, MAT. You all are so on top of this.
All right, great job, everybody. let's go ahead and take a look at our next example. And here, what we're going to be looking at is a rhythm that I'm going to point out is clearly not sinus. I can see a P wave that is not propagating into a QRS complex. We have a dropped beat. And furthermore, I'm going to say that we do not have a regular rhythm because the R to R interval is dramatically different between beats. And so I'm going to make the case here that because we have an irregular rhythm and we have dropped beats, we are probably looking at a kind of heart block, meaning the P wave is not propagating down to the ventricles all the time. So we'll take that as a given. What kind of heart block is this? That's my question to you guys in the chat box. Got a couple answers here, see if people agree. Ooh, all right, guys are killing it. So this is Mobitz type 2 most likely. And the question would be, why is it second degree type 2 as opposed to type 1? In second degree type 1, it's a predictable dropped beat. You can see that it's coming because you can see that the P wave is going to be further and further and further from the QRS complex. Here, that's not happening. We just have out of nowhere a dropped beat. To say nothing of the fact that there's 2 dropped beats in a row, which generally indicates that we're looking at second degree type 2. But we knew that it was second degree because second degree means irregular rhythm. There's no irregularity. There's no R to R interval changes in first degree or even in third degree for that matter. So we knew that we were in the middle here with the second degree heart block. All right, excellent job, everybody. Moses, I'll pivot over to you for our next one here.
Here we have a tachycardia. You know, if you look at some of these beats, it looks like there's 2 big boxes between the QRS complexes. So 300 divided by 2, 150. So clearly in tachycardia. And then the next step, as we learned from Joe, is narrow to wide. And here we have a wide complex. So, and then after that, we look at the actual QRSs. Are they monomorphic or are they polymorphic? Is the morphology of each of these beats similar to each other, or do they change over time over the rhythm strip? And folks are already chiming in the chat. I love the enthusiasm. We're seeing here monomorphic ventricular tachycardia. So this is a regular wide complex tachycardia. Could be associated with a myocardial infarction, for instance, around a scar, as an example that we showed earlier in the webinar.
All right, excellent. So I'll go ahead and throw this one up and give you a hint on this one by saying, all right, I have this particular appearance down here of kind of like a sawtooth baseline. And as I'm counting this out, I have 1, 2, 3 of these little bumps before a QRS complex, which is a big bump. And people are already typing the answer. So if you've got an answer, go ahead and shout it out in the chat box here. This is what we had seen before. It is excellently stated, a 4-to-1 atrial flutter block that we're seeing in this case. So that's our A flutter once again, which has a very characteristic appearance, the kind of sawtooth appearance of the baseline where it looks like literally the teeth of a saw is the main thing that we're going to look at here. So this one is almost immediately recognizable to you guys now. Excellent job running through and immediately giving me the answer to that one. Great job. All right, so Moses, go ahead and walk us through this example.
Perfect. So here, assuming we're looking at a full sort of rhythm strip, we have 1, 2, 3, 4, 5, 6. So we're bradycardic, right? Rates in the 30s. So then we're trying immediately. Are we dealing with first, second degree, Mobitz 1 or 2, or third degree? First thing that I'm looking at, and Joe's already ahead of me by highlighting it, regular or irregular. By my eye, it looks pretty regular, right? And then I look at the QRS complexes, and I see that it seems to me that they're marching out pretty regularly at a higher rate than the ventricles are marching out on this strip. So if I give you all the info that there is a ventricular rate that's going at a slower rate, and then a separate atrial rate, and it's regular and it's bradycardic, folks are already giving the answer in the chat. Beautiful, third degree AV block.
Nailed it. And you guys are doing a great job here, throwing these answers out here as soon as you realize what's happening before we can even get to the end of it. You guys are mastering this stuff. Excellent job. So let's tie together what we've talked about so far tonight as we start to wind down a little bit more here. We're going to be here to answer any questions you guys have, by the way. So if you have any questions about anything we talked about so far or EKGs on any exam in medical school or beyond, go ahead and type those into the chat. We'll do our best to address anything before we wrap up for the evening. But just to kind of close out, the big thing here is that when you see a rhythm strip or you see a 12-lead EKG that includes a rhythm strip, your 5 steps here are going to be rate, rhythm, axis, intervals, morphology. Now, what you might have noticed in the questions that Moses and I did together, especially for those rapid rhythm strips, in many cases, you can really just go through rate and rhythm and it gives you the answer already. You don't always have to consider axis. You don't always have to consider intervals, but you should think about them, especially if you haven't satisfied your search with rate and rhythm. And morphology sometimes plays a role and sometimes does not, but you should always be thinking through these things when you see a rhythm strip. One thing that we didn't emphasize too much that I really want to hammer home here, though, is that in many cases, the clinical vignette they give you itself in these questions on these exams can likely give you a good direction to head in terms of like identifying what kind of problem the person likely has and trying to make a clinical diagnosis before utilizing the EKG to verify your diagnosis is going to be the strategy that we're going to advocate here on these questions. So while we did dive straight into the EKGs tonight, because that was our focus in terms of like learning how to read these things, we do want to still advocate that you carefully read questions, read through entire vignettes, and use the EKG to bolster the diagnosis that you're already formulating based on the clinical information provided. In some cases, there might not be too much in the actual body of the text to tell you anything. You have to rely on the EKG, at least give it a good try before you lean entirely on the EKG for your diagnosis. We talked a lot about tachyarrhythmias. Big thing is wide complex versus narrow complex. Is it supraventricular, narrow complex, or is it ventricular, wide complex? As far as bradyarrhythmias, we spent a good amount of time talking about our heart blocks here and specifically emphasizing that we have irregular rhythms for second degree heart blocks, whereas first and third are both regular. And we have dropped beats in second and third degree together. And we're going to treat first degree and second degree type 1 by doing nothing. And we're going to treat second degree type 2 and third degree by using a pacemaker and implantable cardiac defibrillator. So I'll go ahead and tell you guys a little bit more about who we are at Med School Tutors as we close out here. Go ahead and keep typing your questions into chat. We'll go ahead and answer those as we're able to. Just to reiterate and give you some information about us at Med School Tutors, we're primarily a one-to-one tutoring company that works with students from everything from MCAT all the way up through step 3 and board exams in residency, including applying to residency and things along those lines. Big emphasis on step 1, step 2, level 1, level 2, and the exams in medical school, of course. In particular, you'll meet with somebody like Moses or myself if you were to connect with Med School Tutors over camera like this. And our main goal is to teach material on a one-to-one basis over the computer, over Zoom. But we also act as mentors to help craft study schedules, develop plans of action for preparing for these big exams, and then also to develop plans of action for how to approach things like rotation scheduling, applications to residency, and things along those lines. Generally speaking, we try to form a mentorship bond here where we're helping you become the best possible student and clinician that you can be. In many cases, we stay in contact with our students after working with them for months and years afterwards. And I always really like hearing from my students as they're applying into residency if I work with them for step 1 or step 2 or something along those lines. So if you're looking for somebody who might potentially be able to help you become the best student clinician that you can be, feel free to reach out to us. It doesn't have to be a lifelong partnership, though. If you are eager to just get a little bit of advice in a one-time session, you can, of course, contact us for that as well. We can sit down and in an hour or two kind of hammer through planning out maybe like clinical rotations, application strategy, or things along those lines. So we've got our contact information on the screen. Feel free to reach out to us if you're interested in partnering with somebody from Med School Tutors. In the meantime, we'll do our best to answer any remaining questions you guys have about EKGs for the USMLE and COMLEX exams. Moses, did you see anything pop up as I was wrapping up there?
Yeah, I think one thing to reiterate and really hammer home is the tricky business of telling apart the higher degrees of AV block. So just to give you all the high level strategy here is to determine whether there is a regular appearance to the rhythm strip, which either implies a first degree AV block, just the PR interval is longer than you expect, or it's third degree, the atria and the ventricles are operating independently. And what's happening is that there is automaticity in the atria, and they're firing at a particular rate, and the ventricles have like an escape rhythm, so to speak. The body compensates. It's an amazing sort of machinery that knows that if there's interruption in the communication between the atria and the ventricles, you still want cardiac output. So the ventricles have a native sort of rate at which they will fire, the myocytes, they will fire, but it's much slower than the atria. So in healthy hearts, the ventricles never get a chance to exert themselves in terms of a rate because they're receiving their control and their signal from the atria. But because in third degree AV block, the atria and the ventricles are not communicating, the ventricles are moving at their much slower independent rate. So you will see that it's regular. You will see no association between the P waves and the QRS complexes, and the QRS complex might be a little wide. In contrast, Mobitz type 1 and type 2, there is an association, although it's not consistent, between the P waves and the QRS complexes, and it's technically speaking, I suppose, it's really only in Mobitz type 1 or Mobitz type 2 that you have dropped beats. Because in first degree AV block, you have no drop beats, and in third degree AV block, it might look like there's dropped beats, but there's nothing really to drop because there's no communication in the first place. So it depends on sort of semantics, but high level, regular, with no association between the P waves and the QRS complexes, that's what defines third degree AV block.
Excellently stated. All right, so it looks like that was the only dangling question that we had left. So Moses, anything to say to our students as we close out for the evening?
I would really just echo, Joe, what you were saying, and that we're all on this journey together. I think you can tell that we're, well, maybe I'll speak only for myself, nerds about these things. We really enjoy talking about them. This can be challenging material, but with effort, you can absolutely master it and do well on these exams. And we individually and at Blueprint Med School Tutors would be happy to be a part of that process for you. So I hope you all have a wonderful evening and good luck with any exams that might be in your near future.
Yeah, I'll echo what Moses said and say thank you very much, everybody. We hope you do really well in your exams. Best of luck, and we'll see you in our next webinar.